Welcome to our podcast series discussing treatment-related adverse events with Enfortumab Vedotin in the management of urothelial carcinoma. We introduced the topic in our first episode with Dr. Blais, who is a medical oncologist and director of clinical research in thoracic oncology at the CHUM, and adjunct professor at McGill University in Montreal, Quebec. Dr. Claveau, a dermatologist specializing in the diagnosis and treatment of melanoma and skin cancers, and an associate professor with the Department of Medicine at Laval University, guides us through this discussion. In this first episode, we discuss the evolution of therapy from chemotherapy to treatment with novel therapies such as Enfortumab Vedotin or EV. We then focus on the key clinical trials examining the efficacy and safety of EV for the treatment of urothelial carcinoma. Hope you enjoy it.
Hello, everyone. My name is Claveau, dermatologist at CHUM de Quebec. I have the pleasure to work today with Dr. Blais, professor of medicine and medical oncologist at le CHUM. And we're going to speak about the new development in the urothelial carcinoma. So, Dr. Blais.
Good evening. Hello, everyone. The objectives for tonight are actually to talk about a new and exciting compound that's being used for locally advanced and metastatic urothelial carcinoma. So we're going to focus on Enfortumab Vedotin, which is now regularly used to treat this disease. So we're going to talk about its indication. We're going to talk about different management issues, including the adverse events. And we're going to focus with the presence of Dr. Claveau to guide us about different skin reactions we can see with this product and how we can learn to manage them. The common situation in metastatic urothelial carcinoma is that this disease is really difficult to treat for most people. We find that a lot of patients have comorbidities, have vascular disease, have many tobacco-related disease, which obviously is the cause of urothelial carcinoma for most patients. And these comorbidities associated with age make it difficult to treat most patients. These patients all have some form of renal failure as well, so that contributes to us not being able to treat most patients that would need some form of treatment to potentially prolong their disease and potentially even have long-term remissions from treatment. So for the patients that can be treated, the standard of care in Quebec and Canada is usually using platinum-based doublets. So that's still the standard of care for most patients. And patients that progress on platinum-containing agents usually go on to use immunotherapy, and eventually down the line can get other treatments that we'll discuss.
Dr. Blais, can you explain us a little bit the actual algorithms for treatment of urothelial carcinomas?
The usual standard of practice in Canada is to use platinum doublet chemotherapy. There was indication for immunotherapy in patients that are not eligible for chemotherapy, but that is not reimbursed in Canada. So essentially, patients are selected to receive a carboplatin or cisplatin combined with gemcitabine. Dose-Denzenvac is not regularly used in the advanced setting. And then patients that are either stable or responding to chemotherapy move on to avelumab maintenance, whereas patients that are progressing after chemotherapy, instead of using avelumab, they'll be using pembrolizumab, essentially because pembrolizumab has been studied in the progressive space and avelumab has been studying in the patients that are stable or responding. Enfortumab Vedotin, the drug that we're going to talk about a lot tonight, is mostly used in patients that are progressing after chemo and after immunotherapy. So essentially a third agent that's being considered for that disease.
What is the mechanism of action of Enfortumab Vedotin? It's a targeted therapy, I believe.
So it's a combination of targeted and chemotherapy. And we'll see later on that the side effects of enfortumab are linked to the cytotoxic activity of this antibody drug conjugate. So these types of drugs are abbreviated ADCs to mean antibody drug conjugate. And from the composition of this molecule, it's an antibody combined linked to chemotherapy drugs that are essentially being internalized into cells. And when this compound is degraded by the lysosome, the chemotherapy part of this drug, which is monomethyl auristatin E, very hard name to pronounce, even when we're used to it. And so this compound is a cytotoxic portion that is going to be involved in the cytotoxicity of the cell, but it can actually also diffuse outside of the cell and have a bystander effect. So this will probably explain a lot of the non-tumoral side effects that this drug can have.
What are the main studies demonstrating the efficacy of Enfortumab Vedotin?
This enfortumab has become a standard of care. So that was based mainly on EV301, was a randomized trial that compared Enfortumab Vedotin with third-line chemotherapy. So it used to be that taxanes like docetaxel or paclitaxel would be used in patients with no other option. So this was the proof of concept trial and the registration trial for enfortumab that essentially was able to show that we could improve survival with enfortumab vedotin compared to what was considered to be poorly active chemotherapy. So EV301 showed that we could increase the survival probability by 30%. And we also showed that we can increase progression-free survival. We could improve overall response rate. We could actually double this response with about 19% with chemotherapy, which we've seen in other similar trials using taxane type of chemotherapy, increase that, doubling it to around 41% with enfortumab vedotin. So very powerful drug, enfortumab vedotin, which leads to, as I've mentioned, increased in very important outcomes for patients in this category of treatment.
Can you tell us about the safety profile of this new treatment?
So it's probably going to be important for everyone to consider that even though we tend to see this agent as an antibody, because enfortumab, makes us think that it's an antibody type drug, and we're used to giving antibodies where we don't need to adjust dose. We just give the antibody at a certain fixed interval of time, and we don't tend to see dose-related toxicities. But we will have to learn, and I hope the audience tonight remembers that there's a chemotherapy aspect of this agent that we can modulate by decrease the dose, adjusting the intervals, just like we do with chemotherapy. And if you look at the side effect profile, you'll see that it's very much like chemotherapy in terms of the possibility of alopecia, neuropathy. So the linked cytotoxic compound has some neurotoxic potential. So that has to be remembered. A lot of side effects in the skin that you'll probably talk to us about later, Dr. Claveau, and some digestive aspects, and as well as hematologic side effects. When we compare these side effects to chemotherapy, it tends to be relatively similar to what we can expect with taxanes that give hematologic side effects, that give neuropathy, and on the opposite of taxanes, we'll see a little bit more skin and corneal toxicity. If we want to break it down by the frequencies of these adverse events, we tend to look at adverse events in terms of all-grade toxicity, And we also tend to look at grade 3 or higher toxicity. But in my personal experience, especially for skin toxicity, corneal toxicity, neuropathy, a grade 2 is a very significant side effect. And we wouldn't want to get into a situation where we're pushing treatment in a patient that has a grade 2 toxicity. I tend to be very proactive when I manage my patient with this agent, and I've learned to dose reduce very fast to avoid getting into these significant toxicities. So in terms of magnitude, we see that ocular toxicities occur in about 1/5 of patients, dysgeusia in 1/4 of patients, skin reaction in up to half of patients. So that's going to be a very significant issue to discuss. Hyperglycemia, especially in patients that have underlying diabetes, can run into issues. So it's important to follow blood sugar in patients, especially the diabetics. Some digestive issues, diarrhea, nausea, decreased appetite in up to 1/3 of patients. Some infusion site reactions, which are pretty rare. And as I've mentioned, some occasional hematologic toxicity, mostly manifest by decreased neutrophil counts. The side effects, talking about side effects, when we compare Enfortumab Vedotin with chemotherapy, can occur at different time intervals. We tend to see the skin reactions much quicker than neuropathy. We tend to see the ocular disorders a little later than skin reactions. And we see hyperglycemia relatively quickly. So in terms of sequence, we're going to see the skin reactions first, potentially eventually dry eyes, corneal abrasions, blurred vision. So that can happen in further cycles of treatment. And so that will lead us to manage our patient differently according to where he's at in terms of his treatment.
Now we see that there is more and more combination or sequencing of those treatments. Can you tell us about the usage of Enfortumab Vedotin in combination with immunotherapy anti-PD-1?
The combination of Enfortumab plus pembrolizumab has been approved by the FDA now. So it's expected that this combination will play a bigger role in the frontline treatment of patients. The approval by Canada has not happened as of April 2023, but we can expect that it might be approved in the future. But it probably will depend a lot on the results of this trial that is done, but where the results are not available yet. We participated in this trial at CHUM, was comparing Enfortumab Vedotin plus pembrolizumab compared to our standard of care, which is gemcitabine and platinum chemotherapy. And we don't have the results of this trial yet, but the results of the phase 2 trials of Enfortumab and pembrolizumab were so encouraging that this is the data that led to the FDA to approve this combination before the randomized trial results have been shown. And this is EV103. This is one of the important data sets that has pushed FDA to approve this combination. So these patients were included to receive either EV plus pembro versus EV monotherapy in successive cohorts. So it's essentially a phase 2 trial. The overall response rate for the combination is around 65% compared to EV monotherapy that has still a very nice response rate of 45%. So quite impressive results, very encouraging, and we expect the randomized trial that is complete now to be presented in the very near future. And a lot of people are expecting that EV plus pembro might move in the first line space and replace our standard chemotherapy agents in this population of patients. When we look at EV plus pembro compared to EV monotherapy arm in the first line space, we see from the results of this trial and from my personal experience that we are going to see potentially more EV-related side effects. We might see more combined side effects that are related to the immune adverse events of pembrolizumab, plus the potential cytotoxic effects of enfortumab. We talked about half of patients having adverse reactions with enfortumab vedotin alone. In the single-arm trial of EV plus Pembro, we had up to 2/3 of patients with all-grade skin toxicities. So potentially more toxic. So we'll have to learn how to manage this combination very precisely to decrease the doses of enfortumab, not push the drugs when patients come with side effects, and learn how to work together with our colleagues and potentially mostly dermatologists to be able to help us to give the optimal results that we can get with this very efficacious treatment in the future.